The following presentation is going to cover the 6-step interpretational process of the 12-lead EKG. There should always be a systematic approach whenever you interpret a 12-lead, so we're going to cover that today. With any diagnostic process, there needs to be a systematic approach, whether it's for patient care, lab values, blood gases, or even fixing machinery. You should always approach it with a step-by-step process. 12-lead EKG interpretation is no different. For this course, I have created a specific 6-step process to help understand and interpret 12-lead EKGs. The steps are as follows. Step 1 is general impression. Step 2 is calibration. Step 3 is your rhythm determination. Step 4 is your QRS assessment. Step 5 is hypertrophy. And Step 6 is ischemia and infarctions. I would like to briefly explain why I actually place ischemia and infarction in the last part of the interpretation process. Many students and colleagues in the past have asked me why I chose to place the most important part of the interpretation, determining heart attacks, last. The reason I did this is for two basic reasons. Number one, when you get done with this course, you will know how to identify a lot of cardiac anomalies on the 12-lead, including heart attacks. If you know how to interpret multiple anomalies, then you would look at the 12-lead EKG and the general impression in Step 1, and you would immediately see the ugly morphologies consistent with myocardial infarctions. If you notice this, you should immediately treat the patient based on their symptomology. You should not have to go through all 6 steps to figure out that the patient is having a heart attack. The second reason is that not all ST segment changes are indicative of an MI. There are several ACS imitators that can mimic ischemia and infarction. If you follow the 6-step process, you will be able to identify some of these imitators, and that may actually change your overall 12-lead interpretation and possibly your patient treatment plan. So let's go ahead and cover the first step, general impression. With the general impression, you want to notice anything that might actually first stick out in the first couple of seconds that you glance at the EKG. It's a quick glance at the EKG looking for 3 potentially dangerous items. 1. Excessively fast rhythms. 2. Excessively slow rhythms. Or 3. Any kind of ugly morphologies. So let's just practice a couple of these EKGs real quick just to give you an idea of what I'm actually looking for. When you first look at the EKG, what you want to do is you just want to take a quick glance at it. So what I'm going to do is I'm actually going to show you a 12-lead like this, and then I will, after a couple seconds, I will turn it off just like this, and then discuss what we might see, and then turn it back on. That quick glance is what you want to look at. You want to just briefly look at it immediately and say, do I see anything excessively fast, excessively slow, or any ugly morphologies? In this case, you can bet that the first thing that hopefully you see is that it looks fast. So in my 6-step interpretational process over here, what you're going to do is you're going to come over here to general impression, and you're just going to put looks fast. That's all you need to put for general impression. The reality is that this is a EKG that has a heart rate of about 150 beats a minute. So let's go ahead and look at the next one, and I will turn it off briefly after a couple seconds. So just take a quick glance at it and see, what am I looking at specifically? Is it a little fast, a little slow, or does it look ugly? If you looked at the quick glance, you would actually see that it looks a little bit slow. So I'm going to turn it back on here. So what you want to do is under the general impression, you can just put looks slow. That's your general impression. And if you also are really good at this, you might actually see that there might be some ugly morphologies in there, but we'll get to that stuff later. Here comes the next 12-lead. Just by looking at that 12-lead, does it look fast, does it look slow, or does it look like it was ugly? Well, if you look at the 12-lead now, it actually does look a little bit slow, and there are ugly morphologies. So you can write in here Look slow with, that's supposed to be C with a line over it, ugly morphologies. Now, as you go through the interpretational process, you will eventually find out what exactly you're looking at and why it looks the way that it does. But right now, I just want to concentrate on general impression. Now let's move on to step 2, calibration. Calibration on the EKG printout is important because it will tell you how fast the paper is printing and the amplitude or gain or sensitivity, whichever you want to call it, of the monitor itself. To determine the calibration, what you actually need to do is you need to look for something called calibration markers on the EKG. Usually these markers are found on either the far left of the EKG or the far right. In this picture, the calibration markers are located all the way to the right of the EKG and found as a vertical square in this case. So here would be the calibration markers on this EKG right here. It is not uncommon though that in some situations you will have calibration markers that will also occur here that will start in each lead just before it actually starts printing. You will always have a calibration marker. The machine should always print up a calibration marker, and these mean something different. So let's go ahead and talk about what these mean. A standard or normal 1 millivolt calibration is going to have a marker that is 10 millimeters or 2 big boxes tall and 5 millimeters or 1 big box wide. A marker with these dimensions means two things. Number one, the 5 millimeters or 1 big box wide means the EKG was printed at 25 millimeters per second, which is the standard print speed of heart monitors. So if you look down here, we have 1, 2, 3, 4, 5 boxes wide. So this is the equivalent of 1 big box, which tells me going in that direction that this is printing at exactly 25 millimeters per second, which is the standard print speed in healthcare. The 10 millimeters tall means that the sensitivity of the monitor is set at 1 times or standard sensitivity. So if you were to actually look here and count 1, 2, 3, 4, 5, there's 1 big box, 1, 2, 3, 4, 5. There's 2 big boxes. So if you were to march these out, you could actually see that there are 2 big boxes going up. This means that it is standard height or standard sensitivity set at 1 times. This EKG will have a standard calibration. Now let's look at a couple different calibrations here. The first marker that you're going to see here is going to be 1 big box wide and 2 big boxes tall, indicating standard height or amplitude and a print speed of 25 millimeters per second. So like we just said in the previous slide, if you look here, it's exactly 1 big box wide, which tells me that it is printing at 25 millimeters per second. It is exactly 2 big boxes tall, which tells me that it is normal amplitude or normal sensitivity set to 1x or 1 times. Now let's see what happens if someone changes the amplitude from 1 times to 2 times the size. Basically, the monitor is set to double the amplitude of all of the EKG components. Doing this changes the calibration marker from 2 big boxes tall to 4 big boxes tall, but since the print speed was not changed, the marker is still 1 big box wide. So if you look at the 2 times normal calibration, you are still 1 big box wide, which means you're still printing at 25 millimeters per second. But since you doubled the size of the EKG components, now your marker is going to be 4 big boxes going up. This means that you basically doubled the amplitude over here, so now it is a 2x, not a 1x. What if someone were to change the amplitude to half standard? This means that the amplitude would change from 1x to 0.5x, or 0.5 times. The marker now changes from 2 big boxes tall to only 1 big box tall. Since the print speed wasn't changed, the marker is still 1 big box wide. So if you look at the last one over here, this right here indicates that you're still printing at 25 millimeters per second, but since you're actually only 1 big box tall, then that means that you're printing at 1/2 times the amplitude. So you're actually at 1/2 x. This is an example of a marker that is standard amplitude with a print speed of 50 millimeters per second rather than 25 millimeters per second. Notice how the marker is 2 big boxes tall and 2 big boxes wide as well. So if we were to count this, here is 1, 2, 3, 4, 5. There's 1 big box tall. 1, 2, 3, 4, 5. There's 2 big boxes tall. So I know, since this is 2 big boxes tall, I am printing at standard size. But normally, this is supposed to be, 1, 2, 3, 4, 5. This is 5 little boxes. This would make it a 25 millimeters per second. But since we doubled the print speed, we are now actually printing at 50 millimeters per second. This changes all of our intervals, because at 25 millimeters per second, this little box right here is actually 0.04 second. But if we actually double the print speed, this little box here is no longer 0.04 second. It is now actually 0.02 second, because it prints much quicker. So this would throw off all of our intervals, so we can no longer say that 3 little boxes is 0.12. If we want to look at 0.12, we now have to look at 6 little boxes. Now let's look at some EKGs using the first 2 steps of the EKG interpretation process. We will determine the general impression and the calibration. Here we go. Quickly look at the general impression. Now, did that look excessively fast, excessively slow, or have ugly morphologies? Hopefully what you saw was that it looked excessively fast. So if we go back here to our 12 lead, we're going to go down here to our interpretation process down here. Our general impression is looks fast. Now that we've done our general impression, now let's move on to our calibration. The calibration markers on this 12 lead are way over here on the right side, which you can't quite see the end of it, but we're just going to say that this is a standard calibration. So the calibration is you're going to write standard for calibration. Now let's try the next one. When you quickly glance at the EKG, does it look excessively fast, excessively slow, or does it look like there are any ugly morphologies? Well, just like before, because we've seen these 12 leads before, this one here is going to looks slow. Where is our calibration markers? Well, our calibration markers are way over here, and you can actually see that these markers are 1 big box wide, 2 big boxes tall, which tells us that this is going to be standard calibration. Let's look at one more. It's going to be the same one that we had seen earlier, so let's go ahead and look at that real quick. As you glance at this, you want to say to yourself, is it excessively fast, excessively slow, or does it have ugly morphologies? Well, in this case, we have 2 problems, because if you glance at it, it looks slow, and it's ugly morphologies. But now we actually want to look at our calibration. Looking over here, you can see our calibration marker. There's 1 big box wide, 2 big boxes tall. That makes it a standard calibration. And that's where we stop with our interpretation as of right now. Now we're going to move on to step 3, rhythm interpretation. I'm not going to actually show you the entire rhythm interpretation process. That can be a whole 4 or 5 week class or a whole weekend class all within itself. But what you're going to do is you're actually going to interpret the rhythm next on the 12-lead interpretation process. To do this, you're actually going to look at the rhythm strip at the bottom of the 12-lead. This strip is a continuous strip that goes along the entire length of the 12-lead and is normally either lead 2 or lead V1. So to interpret the rhythm, you're actually going to look down here at the very bottom of the rhythm strip to interpret the rhythm. Now most EKGs will actually have this rhythm strip down at the bottom. If they don't, then you just have to use these leads up here and try to figure out the rhythm. The problem is it only goes for a couple seconds and then the rhythm will change. Once it actually hits these little markers right here, the rhythm will change, which could change your P wave, which could change your QRS. It's always nice to have the rhythm strip down here at the bottom. But whenever you do actually have the interpretational process, what you're going to do is you're going to look at the rate, regularity, the P wave, the PR interval, the QRS complex, and then that will all hopefully help you interpret what your rhythm is. Step 4 is actually the QRS assessment. Now we're not going to get heavily into the QRS assessment because the QRS assessment and the rest of these steps are actually specific components in this course. So step 4, I'm just going to briefly cover the rest of these and then we'll practice a little bit using the first 3 steps, the general impression, calibration, and the rhythm interpretation. So step 4 is going to be the QRS assessment. In the QRS assessment, you're going to look at the R wave progression, you're going to look at the QRS complex, and determine the QRS axis and the hexaxial leads, and then you're also going to determine bundle branch and fascicular blocks. So there are 3 subcategories for this one, all of which will actually be covered later. For R wave progression, is it going to be good or poor R wave progression through the precordial leads? For the QRS axis, is it going to be normal, right, left, or indeterminate? And the bundle branch blocks, you can have a right versus left, and you could also have anterior versus posterior fascicular blocks. The 5th step is going to be hypertrophies and chamber enlargements. Atrial enlargement and ventricular hypertrophies will also both be covered later, but we'll talk about them briefly. For atrial enlargement, since the P wave is the atrial depolarization, then atrial enlargement is determined by looking at the P waves in particular leads. And since the QRS complex is ventricular depolarization, we will look at the QRS complexes in particular leads to determine right versus left ventricular hypertrophy. Step 6, or the final step, is going to be determining ischemia and infarction. The final step is actually broken into 3 sub-steps. What you're going to do is you're actually going to look at ST segment elevation, ST segment depression, and pathological Q waves. All of these will be covered later in a specific course. ST segment elevation means that somebody is having myocardial ischemia affecting the entire thickness of the myocardial wall. We call that transmural MI. ST segment depression is actually going to show myocardial ischemia just affecting the subendocardial layer of the myocardium itself. Pathological Q waves, on the other hand, is different from a regular Q wave because this means that there has been complete infarction of the heart tissue itself. Hopefully by the end of the course and after learning each one of the steps, then you should be able to interpret a 12-lead EKG. Right now, what I'm actually going to do is I'm going to show you briefly how to practice interpreting a 12-lead. Now we're only going to use the first 3 steps. If you're not familiar with rhythm interpretation, that's a completely different course. But we're going to talk about general impression, calibration, and rhythm interpretation, and I will show you exactly how to interpret the first 3 steps of a 12-lead. Whenever you take a look at this 12-lead, you actually want to ask yourself, do you see anything excessively fast, excessively slow, or ugly morphologies? When you look at the EKG, a quick glance does not really show anything excessively fast or excessively slow. If you're familiar with what a P wave looks like, you can actually say that this P wave here is notched, and that's not normal. But does it look ugly? Not necessarily. So you can put abnormal P wave Or you could just put looks fine or something along those lines. The calibration, we're going to move on to the second step. Calibration, if you move over here to the side, it looks like it has a standard calibration. So calibration is going to be standard. Now, what about the rhythm interpretation? If you look down here on lead 2, you actually have a rhythm that goes all the way across. So you can use that to interpret your rhythm. So we're going to try to find out what our rhythm is here. If we can find a QRS that lands right about on a bold line, then we can definitely determine it. So we're going to look at this one, and our PR interval looks like it's about 0.20. There's a P wave before every QRS complex. Let's see if we can determine our rhythm. 300, 150, 175. So we'll say that it's a sinus rhythm at, and we'll just say 80 beats per minute. That is the first 3 steps of interpreting a 12 lead. Let's practice with another one. So did that look excessively fast, excessively slow, or did it have any ugly morphologies? Well, it doesn't look excessively fast or slow, but it definitely looks like that there are some ugly morphologies here. So for general impression, you can put ugly morphologies. What is my calibration? Well, my calibration markers are over here. They are 1 box wide and 2 boxes tall, so that means that we have a standard calibration. Rhythm interpretation, we have lead 2 down here at the bottom, so we can actually look here. It looks like that we have a prolonged PR interval, but there's a P wave before every QRS complex. Let's see our rate, 300, 150, 175. So it's closer to, it's pretty close down to 75. So we can call this probably sinus rhythm with a first degree heart block at 80 beats per minute. Let's look at another one. When you glance at that 12 lead, you want to say, is it excessively fast, excessively slow, or any ugly morphologies? The only real ugliness you can see here is your ST segments look a little off, which doesn't actually look all that good. And you can also see here that these QRSs are actually touching. These QRSs look really tall. Does it look ugly? Not necessarily does it look ugly, but you do see some anomalies there. So for general impression, what you can say is tall QRSs, or you could just say looks fine, doesn't look ugly, but it does not look fast or slow. Let's move on to our calibration. What do I see in our calibration? Well, it looks like we have standard calibration. Rhythm interpretation, we do have lead 2 down here at the bottom with a rhythm strip, so we're going to look at this. What is my rate? 300, 150, 175. Looks like we're at 80 again. And it looks like there's a P wave before every QRS. The QRSs are narrow. So we're going to say that this is a sinus rhythm at 80 beats per minute. Let's look at the next one. So go ahead and ask yourself, is it excessively fast, excessively slow, or any ugly morphologies? It doesn't look like that there are any ugly morphologies, and it doesn't look excessively fast, and it does not look excessively slow. So for general impression, you can put looks good, or looks fine, or something along those lines. Calibration, well, let's move over here and look at our calibration. There's our calibration marker. It is 1 box wide, 2 boxes tall, so calibration is standard. Rhythm interpretation, you can actually see we have a lead 2 down here, so we can use this to determine the rhythm right here. And what is our rate? Let's see if we can find one here. 300, 150, 175. So it is right at 75. There are P waves before every QRS complex, and they look like they're married to each other, so we're going to say sinus rhythm at 75 beats per minute. Last one we're going to look at here. Did you see anything that was excessively fast, excessively slow, or any ugly morphologies? Well, if you look at the rhythm, it doesn't look like that you have any excessively fast or excessively slow rhythms, but it does look like we actually have some ugly morphologies. If you would look over here, that looks like an ugly morphology. That does. These look like ugly morphologies. This over here, this is actually maybe patient movement or something, so you can't really use that as a problem. But anyway, this does have some ugly morphologies. Calibration. Now the calibration markers kind of look like they were cut off over here, but we're going to just say that this is standard calibration. 12 lead, rhythm interpretation. We can't really use a rhythm strip down at the bottom because there is no rhythm strip down at the bottom, so you kind of have to look at a couple leads and put these together. So it looks like V3 and V6 are kind of the same. So we're going to look at this. What is our rate? 300, 150, 100, 75, 60. So it's actually a little slow. So we'll say that's about 58. There are P waves that are married to the QRSs. There's one P wave for every QRS. So we're going to say our rhythm is a sinus Brady at 58 beats per minute. Now go ahead and pause the video and practice the next 3 12 leads on your own using the first 3 steps of the 6-step interpretational process. Once you complete the 12 leads, resume the video and see if your answers match with my answers. Please pause the video now. Now let's go ahead and look at the next 3 12 leads. As we look at this one, do you see any ugly morphologies? Did you see any excessively fast or excessively slow rhythms? When we look at the EKG here, it does actually look like that we have some ugly morphologies. If you look over here, that doesn't look right. This doesn't really look right. You actually can see some elevation here and here. That definitely doesn't look right. So there's some ugly morphologies there. Now let's look over here at your calibration. Your calibration marker is 1 big box wide, 2 big boxes tall. That makes this standard. For the rhythm interpretation itself, we don't have a rhythm strip at the bottom, so we kind of have to use some other leads here. It looks like that these P waves are married to the QRSs. Our rate is 300, 150, 175, so it'll be about sinus rhythm at 75 beats per minute. Now take your quick glance. Did you see anything that looked excessively fast, excessively slow, or ugly? Hopefully just by glancing at this, you don't have to be very well trained in the EKGs to know that this right here is a very ugly morphology. It actually looks a little fast as well, so we're going to say that ugly morphologies. Calibration, if you look over here to the left side of the 12 lead, you actually have standard calibration. Now the rhythm interpretation, we don't have a rhythm strip at the bottom, but we can use this other stuff up here. It looks like that those might be P waves, but we're actually having trouble telling. They might be P waves. It's very irregular, so it looks like that the overall rhythm is going to be a sinus rhythm at, let's say, 300, 150, 175. So sinus rhythm at 90 beats per minute with premature atrial complexes. Finally, the last one. Did this EKG look excessively fast, excessively slow, or were there any ugly morphologies there? Basically, this one right here does not look excessively fast, it does not look excessively slow, and it doesn't really look like that there are any ugly morphologies. So in our general impression, we're going to go ahead and write looks good. Calibration, if you come over here to the right side of the screen, to the left side of the screen here, you'll see our calibration marker is 1 big box wide, 2 big boxes tall, so we're going to say our calibration is standard. Fortunately, we do have a rhythm down here at the bottom that's actually V1. This is V1 down here that goes all the way across the screen, so we can take a look at the rhythm down here. It looks like that this is almost a prolonged PR interval, but it looks okay. Our rate is 300, 150, 100, so it's about 95 to 100. P waves before every QRS complex. Looks like they're married to the P waves. So our rhythm interpretation is going to be a sinus rhythm at 95 beats per minute, and that would be the end of our 12-lead interpretation up to this point. If you have any questions at all, please feel free to contact your instructor. Most of the 12 leads that I got were not 12 leads of my own, but they were actually pictures used from this book here, the 12-lead ECG, The Art of Interpretation by Garcia and Holtz, published by Jones and Bartlett.